Good afternoon and welcome to this bill hearing for the House Health Committee. I am Chair Bagnall here with my amazing Vice Chair Cullison and our incredible committee, who I appreciate greatly. I ask for your patience if we encounter any technical or streaming issues. This hearing is being streamed on the Maryland General Assembly YouTube channel, and we do have, I believe, one virtual witness today. Please note that food and beverages are not permitted in the gallery. Delegates may have drinks at their desks as these meetings can run long and hydration is essential. Please make sure to turn off your phones or turn them to silent at this time. If a member is not present during the hearing, please understand that they do have bill hearings in other committees, and we have other meetings, but we are staying informed on the proceedings. Please adhere to our usual committee rules of one question and one answer from the panel, not one question and one answer from each panelist. And please make sure that you keep your questions shorter than the answers. Today's bill hearing is going to go in the following order. House Bill 1593, followed by 1617, 1597, and 1625. Just a reminder that sponsors are not time limited. Today is mostly sponsor only. Delegate Guyton, if you want to come on up to the table and begin your testimony. And welcome back to the Health Committee.
Wonderful committee members on the Health Committee. I miss being in here. This is the only bill I've had in here this year, and that's really different for me. But I am going to, out of respect for all of our time and energy and the fact that your fabulous chair actually pulled this out of rules for me, I'm going to keep this super short, and I mean that. Everyone knows all about the Developmental Disabilities Administration, some of the issues that folks who use their services have been struggling with over the past many years, actually. It's not just the last two. And this bill does a little bit to make their lives a tiny bit easier. And that's because they always look to what's called the Self-Directed Services Manual, which is over 100 pages and which changes all the time, to determine like what is legal, what they need to do to follow the rules to get funding for the services that they utilize. The problem with that is that this manual changes to it do not go through the regulatory process. So if these are regulation changes, they have to have public comment. People have time to digest them, to understand them, and amend them as necessary. Unfortunately, with the self-directed manual, what is really the lifeblood of this program, none of those things apply. So this bill simply says that when changes are proposed to this manual that has all the instructions in it, that the secretary, deputy secretary has to give notice to the people who utilize it and has to allow them to have public comment and cannot make changes to this manual until that public comment period is over. It's as simple as that. The reason behind it, I think, is obvious to this committee because you have heard problems associated with this program for so long, but just a good example is there have been several meetings over the past year where the department has held webinars to try to teach folks what is in the new changes to the manual, only to have people find out that the policy changes in the manual had gone into effect even before they had that meeting. So they were out of compliance already. Or the issues that were being addressed in the policies in the manual required training, but the training wasn't available for weeks or months, even though the actual policies had already been changed, and so they were out of compliance. So this just improves communication and makes the lives of people who are already struggling within the system a little bit more clear and a little bit easier. So with that, I ask for a favorable report on House Bill 1593.
All right, thank you for your testimony. I'm going to open it up for questions from the members, starting with Delegate Rosenberg, followed by Delegate Kaufman.
If I heard you correctly, this is going to be a system like the AELR process, but not the AELR process. Why did you do it that way instead of making it subject to the AELR process? I'm biased, but.
Sure, and what a great process that is, sir, with terrific leadership.
Just follow the statute.
Because yes, and I think because these are policy changes and not regulatory changes, so they do fall into a different bucket than the regulatory changes, but then to be completely honest, the bill was drafted in the Senate first, and I was asked to cross-file, and so this is how it was initially written. I certainly would not be at all opposed to that, but I think as written, this is sort of where we are right now.
Thank you.
Delegate Kaufman.
Yes, I'm just wondering, wonderful to see you, Madam Vice Chair. I'm just wondering if you're amenable to the amendments proposed by the DD Coalition in their letter?
Are you referring to the letter saying that these policy changes and the notification that they will be changed needs to be available in plain language that all can access?
I believe so, yes.
I absolutely think that's an amazing and wonderful positive addition to this bill.
Thank you, Madam Chair.
Thank you, sir.
Vice Chair Cullison.
Thank you, Madam Chair. And in addition to that amazing possibility, there is information from people on the go that are looking for this to extend beyond the self-directed services. So do you know, for the other kinds of services, is there this kind of document that it would apply to, or is it sort of unique to this particular program?
I don't want to guess at that. I have not heard of a document like this one that changes as often without the opportunity for public comment, but I am not familiar with other very specific waiver programs and programs through how they make those changes. I know that this one is the biggest and the most fluid that I think is out there.
Madam Chair, may I ask? Okay, so this isn't necessarily a follow-up, just another question. Just, I will confess I haven't read the bill really thoroughly. Is there a contingency, or not a contingency, but a requirement that the current practice will stay in place until the change goes through this process of change?
Yeah, so there is a requirement that unless they actually start unless they actually make this known to people and allow public comment, they cannot make any more changes.
Okay.
Without.
And everybody would operate under the current situation until that is done?
Yes.
Okay. Thank you. Thank you, Madam Chair.
Yes.
Thank you. Vice Chair Guyton, we do have a proposed amendment from the Department of Health that strikes the language around the public comment period and replaces it with the secretary shall adopt regulations for the community pathways waiver, including regulations pertaining to the delivery of self-directed services. And I think that might sort of create the AELR process. Have you seen this, or have you spoken with the
I have
Department of
not
Health?
seen this, and I don't think it's in my little handy manual that my staff put together.
All right, so perhaps we can have a conversation with the Department of
Sure.
Health and sort of get to the crux of that. Delegate Gazzoni.
Thank you. So, yeah, sorry, that question threw me off. I just wanted to ask actually about the sort of start date, which is in October, and would there be any way that could get moved up to maybe July 1 or even make this an emergency bill?
It would certainly be fine with me if this committee decides to do that.
Delegate Riley.
Chair. So thank you for the bill. So I had a question. So that you said that the manual is fairly lengthy, so a lot of pages. So even though they have this 90-day period and they have the open comment time frame, when the changes are made, how are those changes just made in the manual and then they have access to the manual, or will those changes be like somewhere where they can just go see the changes instead of reading the whole manual?
Well, to date, the problem is that folks usually do have to read the manual, right? Which isn't easy for everyone, especially as, Delegate Kaufman pointed out, if it's not in plain language and easy to understand, and these are families that are already stressed in a lot of different ways. So currently they do, although they do generally say, okay, there are some changes in the manual. We're going to have a meeting, a webinar usually, to explain those to you. And they will have the meetings, people who can attend will attend, and that is when usually they'll say, okay, this is what we're doing. They don't have any input in that, and like I said, sometimes they'll have the meeting after the rules have already been changed and no one's in compliance and they don't have time actually to become compliant with those regulations, with those policy changes.
Okay, so they're going to be notified once the changes are done in the same way? Is that, do they
So there's
get an
nothing- the bill
email or
doesn't-
snail mail?
Yeah, so the bill doesn't really speak to how the department will then roll out the new changes. The bill just speaks to the fact that people will be notified and have a public comment period, have a chance to look at all of the changes and to help, draft them and express their concerns if necessary, which is not something they've had the chance to do in the past.
Thank you very much, appreciate it. Thank you, Madam Chair.
Thank you. Seeing no further questions, this does conclude the bill hearing on House Bill 1593. Thank you very much.
Thank you, Madam Chair.
We are going to move now to House Bill 1617. Delegate Alston, and you do have County Executive Brave Boy in the waiting room, so we'll bring her up for your panel.
Good afternoon, colleagues, Madam Chair, Madam Vice Chair. Thank you all for being here this lovely afternoon. I'm here today to present House Bill 1617, which is Health Innovation Zones. This is a creative way for us to get more healthcare businesses in areas that have been traditionally underrepresented. There is an area where I grew up that has no primary care providers, no specialty care providers, no grocery stores, and no pharmacies. They also don't have a bank anymore. And this is a very urban area with multiple metro stations, lots of people, but the lack of access to appropriate health care is literally killing the residents there. There's a high prevalence of diabetes, hypertension, cancer, you name the medical problem, it is high in those areas. What this bill seeks to do is alleviate some of those problems. And this neighborhood where I grew up is not the only area. We have similar problems in rural Maryland. We have similar problems that have been economically depressed throughout the state. And so by creating these health innovation zones and providing incentives for these businesses to come into these communities and provide services, we can get our Marylanders healthier and on the right track to living a long, sustained, healthy life. I will say that there were some drafting concerns. The first one would be the fiscal note, which comes in at a whopping $5 million. That was supposed to be a note with existing resources so that Medco could fund projects up to that amount with the way that they do funding. They do bonds and other creative ways of providing finances. So it wasn't necessarily for us to obligate money from the general fund. So we will have to fix that through amendment. And the other issue, I don't think it's an issue, but I'm happy to answer questions about any other concerns with the bill. I'm excited to have the support from our county executive, who is here with us today, as well as the Prince George's County Medical Society. And I believe they're here for questions as experts if you all have questions, and I'm also happy to answer any questions. And with that, I'd like to turn it over to our county executive, Aisha Braveboy.
Thank you so much. Oh, was I recognized? I'm sorry, I can't hear.
Please, County Executive, go ahead.
Thank you so much. Good afternoon, Madam Vice Chair and distinguished members of the Health Committee. It is an honor to be before you today. For the record, I'm Aisha Braveboy, County Executive for Prince George's County, a county of nearly 1 million people. One thing that we hold dear here in our county is the lives of our residents, and we don't want an individual's zip code to determine their life expectancy or their quality of life. And so this bill really provides us with an opportunity to incentivize healthcare professionals, grocery stores, and other amenities that will enhance the quality of life to be in every zip code in Prince George's County. As was mentioned by the delegate, We have a lot of needs around primary care. We also have a lot of needs around wellness. And we really want to incentivize businesses to come to certain zip codes in Prince George's County. Right now, along the Blue Line corridor, we are building out a health enterprise area where we can incentivize businesses in the healthcare industry to locate close to our hospital. And we really appreciate the opportunity that this bill would provide to incentivize those businesses to want to move there. It has been tough to get healthy healthy restaurants, grocery stores, even primary care physicians, specialists to want to locate in certain areas of our county. And that places a huge burden on those residents who, in many cases, don't have access to transportation to get to places that are outside of the county or on the other side of the county. So we want people to be able to get and seek health care where they live, and we want them to have quality grocery stores and other amenities where they live. And this bill will assist us in making that a reality for all Prince Georgians. So thank you very much.
I'd like to open it up now to questions. Seeing none, I have a question. I'm sorry, Delegate Gazzoni.
Thank you, Madam Chair. Could you, Delegate Alston, run me through the fiscal note challenge again?
Yep. As drafted, it says that it's an obligation from the general fund. What it was supposed to be was resources coming from Medco's existing fund up to $5 million. So they have their own means of raising capital. I spoke with them today. We need to have a further conversation about how the bill needs to be drafted. They didn't come in opposed, but probably because they thought they were getting $5 million from the general fund. I wouldn't have been opposed either. But that was not the intent of this drafter, so we just need to fix that. Yep.
Okay, thank you.
I'm not seeing any other questions. I'll ask. So this bill essentially would authorize this in all counties in Maryland. But you speak specifically to Prince George's County, so maybe this is for the county executive. So there's an interest in the county to designate the zone now. Is that what your thoughts are?
That is correct. We want to capitalize off of the work that we're doing around the Blue Line corridor. Our hospital, Capital Region Health, is actually located close to one of our metro stations along the Blue Line, which is Largo. And between Largo and Morgan Boulevard, we want to build out a health care campus. And currently, that was the plan all along, apparently. But the only thing we have there right now is just the hospital, and we haven't been able to truly incentivize other providers to locate there. So this will give us additional tools to really build out what was the vision for this area.
By giving you greater access to the Medco, the Medco funds, correct?
Yes.
Right. Okay, great.
Yes.
Great. Thank you very much. Seeing no further questions?
Thank you very much. Delegate Johnson.
Thank you, Madam Chair, and thank you, Delegate. On page 3, it says the county shall establish by law incentives. Any particular incentives you were thinking about?
Well, there's one incentive that has been floating around the General Assembly all year that I would like to see voted, but I don't think it will be. And that is an incentive to allow liquor stores to, for grocery stores to be able to sell liquor. I know it sounds like an oxymoron in the Health Committee, but grocery stores have repeatedly told us, as we're trying to get them to locate in an area that is a food desert, that is something that would incentivize them to come. But we want to do things like fast track the development. we would want to do things like make sure that these businesses have some funding so that they can be sustainable when they open. So providing these businesses with financial opportunities so that they can locate there. And having that capital startup, we believe would help businesses grow and help us have more employees and hopefully more tax revenue for the state.
Follow up. Oh, okay, so how about, are there certain stores that will be excluded from incentives, like dollar stores, for instance, who like to go in, they can go in with a smaller footprint into poor communities, and they don't offer hardly any nutritional foods, but that's what those folks have to consider their grocery store. So are you looking to incentivize those type of stores?
No.
Okay.
No, those are not the type of grocery stores we're looking for.
Okay, thank you. Thank you, Madam Chair.
Thank you. Seeing no further questions, thank you very much, Madam County Executive, for joining us. Oh, Delegate Tavares.
I recall the county having health improvement zones. Why are we not focusing on honing on that?
I think you're talking about health enterprise zones. Did you want to answer that, County Exec, or should I? The health enterprise zones were different. What this is seeking to do is really spur some innovation and get companies that we don't currently have. So with Health Enterprise Zone, it's really focused on like your primary care providers. This also would expand to grocery stores and pharmacies and other things that help make us healthy, not just primary care providers. So it's more expansive.
Can I just have a quick follow-up? Okay. I do think that we do need to be careful with this concept of having alcohol. How do you respond to grocery stores that did offer alcohol and are now closed?
I think you're talking about the Shoppers in College Park that has a Lidl, a Harris Teeter, and a Whole Food all within very close proximity. So I think that it was more complicated than just them having alcohol, whereas the locations I'm talking about, there's nothing for miles upon miles. There were 4 grocery stores there, and one happened to have alcohol, and it wasn't the store people preferred to go to because you also have beer and wine stores, you have spirit stores, you had high-end stores. So it's not as simple as this one store had this, and they closed down, so it doesn't work. It's not that linear. You have to look at the fact that there's a Lidl almost within walking distance. There's a Harris Teeter that's right down the street by the campus. There is a Whole Food that is also right down the street by the campus. And so that store was competing against some very high-end stores. That same store in my neighborhood is one of the few where I live, and it's very profitable. So even though they've closed down everywhere else, they've been able to stay open without the alcohol. But what retailers have been telling the county when they go to conventions is that that is something they need to go to areas like Seat Pleasant, Capitol Heights, Fairmont Heights, where there is a food desert and people don't have an ability to buy fresh fruits and vegetables or meat. And so if they're telling us that, we can try it. If it works, great. And if it doesn't, we don't have to continue doing it. But right now, we have no tools in the toolbox and no options at all. And my people have been suffering for the better part of a decade because of the failures of our ability to get this done.
Can I just follow one more?
No. Delegate Rosenberg.
All right, thank you.
This feels like we're debating a bill that's not the bill in front of us, so I'm going to go to Delegate.
Just to make sure that the bill in front of us authorizes this to take place in any county, but has specific instructions for, or limitations, whatever, as to how it would apply in Prince George's County.
That is correct, and thank you for the observation. Yes, so I recognize that there are innovation needs all over the state. I know that rural Marylanders also need this type of innovation. I know that there are areas in the state that have low income and that have just not had the type of investments that are needed. And so the way the bill is drafted, it should be able to encapsulate those areas as well. I will tell you, originally this was going to be a local bill. I put the request in October. We just got it back. That's why it's now a statewide bill, so everybody can avail themselves to the health innovation zones that we were originally looking to just put in Prince George's County. But, and I think it could be helpful to everyone.
Thank you.
Seeing no further questions, thank you very much for your testimony. This does conclude the bill hearing on House Bill 1617. We're now going to go to House Bill 1597. And Delegate Hill, do you want to just do your bills back to back? So 1597 followed by 1625. Delegate Hill, if you want to go ahead and approach the table and begin your testimony when you're ready.
Approach the guillotine. Thank you very much, Madam Chair, for allowing me to present this bill. Good afternoon to Madam Chair, Madam Vice Chair, members of the Health Committee. I'm Terry Hill, representing Howard County District 12A, and presenting on House Bill 1597 on regulated space and hospital operating suites pilot project. In my written testimony, I've explained to those of you who have not been on the committee for a while that this is a follow-up effort to get a pilot to look at how we are treating people who are having what would be considered cosmetic surgical cases, meaning elective cases that aren't covered by insurance company, but often have, in some cases, medical need. And the fact that our current system makes it almost impossible for a patient to get treatment in get an operation in an operating room that's inside a hospital, whether that's an ambulatory surgical center affiliated directly with the hospital or the hospital itself. And what this means is that we are treating patients based on their diagnosis in terms of where the location for their procedures are, rather than having their procedure performed in the safest place for them to have the procedure, okay? So to better understand, I'm going to actually read from a letter that was submitted by a colleague of mine. His name is George T. Grace. He's the chief of plastic surgery at St. Agnes Hospital, and it is really with him that I've been working for the past 5 or 6 years to try and get around this before we have a disaster where we have patients having surgery in ambulatory facilities because they can't do it at a hospital, ambulatory facilities deciding that some of these cases take longer than they want because they like to do those quick 15-minute cases. And so they may be encouraging people to do it in their office under less than ideal situations or without the right anesthesia. And what we really want is have the right procedure, the right surgery for the right patient in the right place. And he writes, for the last 5 years, Delegate Hill and I have worked on something that I refer to as right patient, right operation, right place. We have a growing population of bariatric patients. Those are people who've had massive weight loss. Unfortunately, these patients post-operatively have multiple problems with their skin. Also, unfortunately, many of their problems are not covered by the insurance companies. To make the issue worse, they're often not candidates to be operated on in the outpatient surgical facility, either because of comorbidities, diabetes, high blood pressure, or because of their actual BMIs. There are other patients other than just bariatric patients that are often referred, but are currently, we're most concerned about these patients. It's important to comment that just because an insurance company says something is not covered does not mean it's cosmetic. To the hospitals, if the insurance company is not covering it, then it becomes a self-pay. This often leads to cosmetic rates, and back in the day when I was first in training, to digress for a minute, hospitals were allowed to charge for self-pay patients a different rate than they charged with the insurance companies. So they could say, well, you're paying, I don't have to wait for a thing, you're going to pay the full price, I don't have to take a cut on it, so I'm going to charge you, $200 an hour, but I'm going to charge the insurance company $500 an hour, knowing they're only going to pay me $200, but I have to wait for that. They're not allowed to do that and haven't been allowed to do that for about 15 years, so they're sort of stuck charging the same rates as insurance company, and that might mean for a 5-hour procedure, let's say a tummy tuck, whereas they used to charge, where a surgical center might charge, I don't know, $12,000 for the facility fee, a hospital would be charging 30 or 40, okay? So it goes on to say if bariatric patients have significant skin issues with rashes or back pain and hygiene problems, but does not qualify under the stringent insurance criteria, they have no option other than to pay for the surgery themselves. Hospitals in Maryland do not provide cosmetic rates, and it's cost prohibitive otherwise. So these patients are forced to go to a surgical center, but if their BMI is over 35, most surgical centers will not take them. This often leads for them to go out of state or out of the country. You may not be aware, but most weeks there are 1 or 2 patients in Baltimore hospitals who had cosmetic surgery in Miami, in Turkey, or in one of the many Caribbean plastic surgery mills that does surgery and sends them home a day or 2 days later. It then falls in our state and the insurance companies, if they have insurance in the plastic surgery community, to take care of their complications. All right? And I'll mention I had a patient a couple of years ago who came to me after being discharged from a local hospital where she had been admitted after receiving surgery in Miami, and had her complications here. And after I treated her for a few weeks, the infection recurred, and she was hospitalized for about 3 months. Okay? So Dr. Grace goes on to say, I also think it's important to note that the great majority of cosmetic patients do not want to be operated on in hospitals. They appreciate and want the privacy of a surgery center. But there are many cosmetic patients that are at acceptable risk for surgery, especially with sedation, which makes many of us feel uncomfortable, or unacceptable, which makes many of us feel uncomfortable operating them in a surgical center. These patients would benefit from having their surgery performed in a more hospital-like setting. And what that means is even if they're being done on an outpatient basis, if the surgery goes long, if they're not recovering quickly, you have the ability to admit them for 23 hours of observation. You don't have that in an ambulatory surgery facility. You also, in an ambulatory surgery facility, don't have the team of people if something goes wrong during the surgery that you can call into the operating room. These are things that hospitals provide. Our hospital, he's talking about, he operates out of St. Agnes, as disclosure, so do I, tries to support the bariatric population. He says, so I operate on somebody from the bariatric program in the hospital operating room because of multiple medical reasons, including the BMI. And the hospital is doing the right thing, but the hospital is being penalized. Whatever rate is set by the commission, the hospital has to charge. By and large, these are not rich people. They are average middle-class people who underwent bariatric surgery and now have significant skin problems. Many are not eligible to be performed at the surgical center. The hospital loses money because whatever the rate the commission says they should charge, minus whatever the patient actually pays because they can't pay the full fee, the hospital loses. So again, the hospital's doing the right thing. They understand the concept of right patient, right operation, right place, but they're penalized for it. And so they try to limit the number of times that they allow that. So we've tried, Dr. Grace and I have tried different avenues to rectify the problem, but we're asking is for the state to allow a pilot program that allows the hospitals without penalty to work with their surgical communities to perform the right operation on the right patient at the right place. And if the insurance denies this as a non-covered event, then the hospital should be able to charge a fair amount of money that the patient can actually pay instead of charging $30,000, $40,000 that they would otherwise charge. And again, we know, you all see your explanation of benefits. Whatever is charged is not what actually gets paid. Those get cut down significantly, but they're not allowed to cut it down for the self-pay patients. Maybe we are talking about the hospitals collecting $100,000 total. It can't be much more. And he says, I cannot speak for St. Agnes, but as section chief of plastic surgery, I cannot imagine that there would be more than 25 cases per year. And I'm going to digress again to say that when I talk to HSCRC about the number of cases, they say it's less than a fraction of 1% of the cases that are having surgeries that this will qualify for. This is not going to generate a lot of money for the hospital, but it's going to improve patient safety. And it rewards the hospital for doing the right thing. We have to find a mechanism for more patients in this situation. We do not want those who can not afford the surgery to have to travel out of state or out of the country. And note again, it's not the surgery they can't afford, it's the hospital fee. We bear the burden of their postoperative complications. So this is a bill asking for a pilot program. There's explanation in the HSCRC's information about why this is difficult for them to do, about the journey that got us to this point. The Hospital Association is also concerned that this will affect their contract under the AHEAD model, and I think these are legitimate concerns. And I guess I would be happy if you all understand why this is an important thing for us to try to address, and if the chair and the committee were willing to help us find a solution, even if that meant pressuring the Hospital Association when they get to carve out under the AHEAD model some bit that doesn't fall under the AHEAD model. If they could take this 1% of the cases they see and exclude them so that patients have the opportunity to have the procedures where they can most safely be done. Thank you.
Thank you for your testimony. Are there questions for the sponsor? Delegate Alston, followed by Delegate Johnson.
Thank you, Delegate Hill, for bringing this very important bill. I had a friend who passed away at a surgery center because his BMI was too high and the surgery was too risky for him to be operated on in that type of environment. And I'm just wondering, how will patient safety be improved, just briefly, under this bill? I know it's difficult for you, but I want to thank you for.
And I don't want to imply that physicians, be they anesthesiologists or surgeons, are sort of negligently disregarding safety. They're actually saying, we think we can get this done here safely. And sometimes they're wrong, but they don't have the other options. And so by having the option that the hospital can allow a small percentage of cases in and know that they're not going to lose money. And these are operating rooms that often are staffed but unused. That's why we talked about a pilot. If you've got the space and you're already paying the staff to be there and there's no case booked, then why not allow them to put these cases in at a fee that is reasonable? That's all we're asking for, and it would be safer because there's less pressure to think we're better at doing what we're doing than we might sometimes be.
Delegate Johnson.
Thank you, Madam Chair. And thank you, Delegate, for trying to look after everybody. But I just have a question I wanted to clear up. The unregulated space, is that strictly spaces outside of a hospital, or is it, then you talk about regulated space. So what's the difference? Is one outside hospital, one's in? Is it one they have total control over the scheduling, and one they don't, and one they have?
Right. So thank you, Delegate Johnson, for that question. Essentially, regulated space is space that falls under HSCRC. They tell them, what they can charge, and there's been this evolution from you've got to charge the same thing for the same case no matter who. And we can go through that history, be happy to explain, because it's evolved over the 30 years since I've been in practice. The unregulated space is the ambulatory surgery centers. And one of the reasons that HSCRC says it will be difficult to do the pilot is they have no idea, they have no eyes in those spaces. They don't know what they're charging. They don't know what kind of cases they're seeing. They don't know what their complication rates are. So to compare what would happen if these patients were done in a hospital to what's happening if they're being done otherwise, you're stuck with looking at who shows up in an emergency room and reports that they've had a surgery and where was the surgery done. because those spaces are not regulated.
Okay, thank you. Thank you, Madam Chair.
Delegate Hutchinson, followed by Delegate Gazzoni.
Thank you, Madam Chair. Thank you, Delegate. Is this at all related, or is it completely apples and oranges to the situation that we saw at Harbor Hospital, where we went to go tour their ORs and they were doing dental procedures there? Is there any similarity, or is this completely different?
There is, it is similar, and they had to sort of look for exceptions to be able to make sure that they could do, those children were not being done in hospitals. And the dentists were in the position of, we cannot do it, but we can try and give them the anesthesia to do it in the office. And so many of those kids were just not getting done. So it's similar.
Excuse me, can I follow up? So, there's opposition in here from MHA. So how's that able to be done, but yet we're not sure whether this can be done for these cosmetic patients?
Well, again, so St. Agnes Hospital, as an example, a few times a year, Dr. Grace will call them and will say, this doctor or this doctor has a patient. This is an appropriate surgery for them. They're either too heavy or they've got an underlying disorder where they should be on some medication around the time of surgery. And he literally goes to the leadership and says, please agree to do this and take a hit. And they take a hit. Other hospitals won't do it. So I would have to look a little bit more to see exactly how they were able to arrange to do the dental cases. But I think some of the things that we did was make sure that anesthesia could get paid. So we changed the rates for those Medicaid patients so that the anesthesiologist could be appropriately paid. And it's just, this was true under the waiver. It's going to be true under the AHEAD model. And I think the one opportunity we have is that the AHEAD model, I think in year 3, allows for the state to carve out certain cases as not falling under the same regulations. We could have avoided this decades ago if, when we talked about an all-payer system where everybody pays the same rate, we recognize that self-pay on something that would never be covered by insurance should never have been part. We were trying to stabilize insurance reimbursement rates, but we captured everything, and this should have been carved out, and we've worked on that in the last 10 years through a number of mechanisms. It's just hard to go backwards once you've captured it.
Thank you. Thank you, Madam Chair.
Delegate Gazzoni.
Thank you, Madam Chair. So I'm curious if this is something that's somewhat unique to Maryland because of our unique payer system, or is this something that because it seems like there's this gap.
Yeah.
Like there's these people over here that are clearly going to ambulatory, and these people over here that are clearly going to be in the hospital, and then these people kind of in the middle. So is this sort of unique to Maryland because of our payer system, or is this something that other states are dealing with as well?
It really is unique to our initial waiver. So again, there was a time when hospitals would charge different, they literally had cosmetic rates, and they had sort of the regular insurance rates. HSCRC looked at that and said, you can't do that. When they said that, I knew hospitals that would say, okay, well, let's do we're going to do rates under these codes, and let's say you had a rhinoplasty, which is a nose job, and you had septoplasty where you're changing the septum. They'd say, well, most of the time a septoplasty is covered under insurance, so we're going to charge this rate. Rhinoplasty is often cosmetic, so we're going to charge this rate. So they tried to get around it by saying it's a breast lift, that's cosmetic, it's a breast reduction, it's not. But what that really started to force is for the provider to misclassify the surgery in order to fall under the proper category. So that wasn't an effective way of doing it. And then some hospitals would use their surgical center, they'd build it attached to the hospital, and they'd say, well, if it's being done in the surgical center, and they'd have to have literally a door, they'd have to have some physical barrier between the hospital operating rooms and the surgical center operating rooms. And then they could say, well, it's not being done in the hospital, these are our unregulated ORs, so we can charge different rates over here. And if there's a complication where we're right at the hospital, we'll just slide through as opposed to having to call on. So, over the years, hospitals have tried to work within the waiver system and the all-payer system that says you got to charge the same thing no matter what the insurance is. But the initial error was never corrected, that it was supposed to be about different insurers, and we captured uninsured cases that would never have been covered by insurances at the same time.
Thank you.
Thank you very much for your testimony and for the bill. And I know that you've seen the HSCRC and the Maryland Hospital Association, and it's clear that there is interest from the committee. I wanted to pull this bill out of rules to make sure that we had the discussion, but we are a week from crossover. We have some challenges, and Delegate Hutchinson brought up the Dento OR, and that was the result of a significant work group that met and sort of worked through how we got access to the unregulated spaces in hospitals for the pediatric dental. To your point, we are still in the ramp up to the AHEAD, and it sounds like the carve out you would be looking at would be year 3, so that is our opportunity. So we have some time. So we've had the discussion on this bill. I don't think we can move forward with the bill as such, but I think you hear a will to work with the HSCRC and work with the committee on how we can achieve the intent of the bill, even if it's not the bill this session.
And I appreciate that. Thank you very much, Madam Chair.
Thank you very much, and thank you for the bill. This does conclude the hearing on House Bill 1597. We're now going to go to House Bill 1625. Delegate Hill, if you would like to approach the table and begin your testimony when you're ready.
All right. Thank you, Madam Chair. Again, Terry Hill, for the record, Howard County District 12A. And this is House Bill 1625, Newborn Screening Program, Fees and Court Conditions. So first, full disclosure, I have sat for the last 2 to 3 years as the House member on the Maryland Newborn Maryland Advisory Council on Congenital and Hereditary Diseases. This is a group with lay members and people with various expertise, but primarily it's a group of people who are in the business of treating pediatric congenital and hereditary conditions, diagnosing pediatric and congenital hereditary conditions, and are the experts on these conditions. Their job is to periodically review genetic and congenital hereditary conditions and determine which ones are ripe for inclusion on our newborn screening. And by ripe, I mean that these are, they have a number of criteria that include, whether or not the condition, if diagnosed early, has a treatment, whether or not that treatment is accessible and available here in Maryland, whether it is equitably accessible, and whether it's going to make a difference in the life or the morbidity of the patient. Those are the main criteria. There's some finesse points to that. And so that's their process. And if they think that a disease should be included that has been previously excluded, they make that recommendation to the secretary, and they can include it. A couple of years ago, we had a bill introduced with a lot of support that said that the feds, the RUSP, which reviews these conditions, has agreed to put Krabbe's disease. You guys may remember that. And therefore, since the feds are putting Krabbe's on, we should put Krabbe's on. And in fact, every time the feds put something on their list, we should include it within 18 months on our screening. We had testimony at that time from the council saying that that's not the process, And just because the feds put it on the list doesn't mean that it meets all of our criteria. But we moved ahead and said that that's what we want to do. We've run into a couple of problems. One of the problems is that we're required to test for Krabbe's. There are at least 2 different types of Krabbe's, one of which, if diagnosed early, there is an available treatment for. The other one, there is not. There's a testing criteria that allowed us to put it on, and the reports from the labs would only report back if a certain threshold on the test were reached to say to the parent, your child is diagnosed as having Krabbe's. If it were under that threshold, they might develop Krabbe's, they might not, but we weren't reporting those out. Within the last year, the labs decided they're only going to report out the number no matter whether it's high or no. So the hospitals, the pediatricians, were now forced to report out, because of this test, that previously would not have been reported to parents because it's a suggestion that you may have this other form as opposed to confirmation. And so we're now reporting to parents for whom there's no treatment, information that we previously would not have known or shared. Additionally, the advisory council at the federal level that makes recommendations about what should be included on the RUSP has now been disbanded, so it doesn't exist. So we're now tied to automatically doing something that the advisory group that advised the feds on what to put on the list is no longer advising on, but the feds may be continuing to put things on the list without any scientific advice. So what this bill does is it says, let's fix this. Let's not get in a pattern of legislating what gets on the list for each disease that finds a legislative sponsor. There are better ways to do this, and can we get back to trusting the experts to do the full evaluation that is necessary to make those determinations and those recommendations. So the way the bill is written, it essentially says that if the recommended uniform screening panel, or the RUSP, puts a condition on, then the department, that the advisory council shall review that condition again. So if they reviewed it 2 years ago, they have to look at it again. If they reviewed it 6 months ago, they have to look at it again and see if there's new information that would make sense to recommend that it also be done. And that the secretary, unless they can justify not adding it, which is the new thing. Previously, we had said the secretary must add it, but we're allowing the secretary to take into consideration our advisory council's recommendation and to make a decision about that. And it's trying to lean back into the fact that we have experts, and we ought to be depending on them rather than a Terry Hill or a Pam Gazzoni or a Shante Martinez or Steve Johnson, for that matter, to sit before this committee and say, put this on the screening. We don't have the expertise. We shouldn't be the ones who are making those decisions. And there are some amendments, I think, that have been recommended that we would be accepting as well.
Thank you for your testimony. Are there questions from the members? Delegate Rosenberg.
Delegate, I heard from a friend over the weekend because of this bill who said that had his child been diagnosed in accordance with, added to the list, she could have been cured, but now she faces death at age 4.
I got the same letter. I don't know the specifics, and I don't know whether the screening test at the time her child was that age was specific enough. What I do know, because I've been serving on the council, and I've gotten in the discussions and the arguments where, I'll give you an example. I wanted us to be testing for cytomegalovirus, because if you diagnose it early in a newborn, you can prevent deafness. And they allowed the case to be presented. And just so you know, anytime, you don't even need to go through this process. Anyone who comes to them and says, we'd like you to review this, they put it on the agenda. It only takes an ask. And they'll put it on the agenda, they'll review the science, and they'll go through it. But, it was reviewed, there were arguments made for and against, and eventually they voted not to include cytomegalovirus. But I understood their process. And that's, I think, the main thing, that there actually is a process that takes into account more than could it have changed this one child. And the other part that the bill does is the fees are being set, but they're not necessarily being set currently based on what it actually costs to run the test. And so this would also fix that.
Thank you.
Delegate White Holland.
Thank you, Madam Chair and Delegate. I appreciate you bringing this bill and elevating this issue. In fact, I was wondering how the implementation of the bill that we had moved forward related to Krabbe's has gone, and even this year we see these bills coming before us. Just to make sure that I understand, can you articulate who specifically pays the fees? And did this concept come up given your participation on the council related to the what it takes to add this on for the council to take on?
Right. So, and I could be wrong, but I think the newborn screenings are paid for by the insurance companies. Okay. What happened was we heard a bill, Delegate Solomon's bill, and he had, it was brought to the council's attention that this bill was being introduced, and as he testified, he actually went to the council about it, and they said, all you have to do was bring it to us. And they were very, very concerned about what his bill would have us do, was just to add it. And they had reasons why they had reviewed that and had decided it should not be added. And in their discussion, it was back to, so now, what are we doing? Every time a delegate wants to add a disease, we're going to add a disease. We don't get a choice about this. We've got a federal advisory group that we can't depend on. Why are we even here? And I said, well, if you feel that something needs to be changed, let's talk about what needs to be changed. So it came out of the members expressing frustration. And that's why we have the bill.
All right, thank you.
So seeing no further questions, Delegate, obviously there is some unfavorable testimony and some concerns that had been raised. And we have some amendments, significant amendments from Maryland Rare, and you said you were amenable to consideration. I just want to make sure that we're setting the legislative record correct as to the intent of this bill, because I was looking through the letter from the Department of Health and from the advisory committee, and it seems like having more time gives them the ability to sort of ramp up to identify the labs, the equipment that's necessary, and also, to your point, to have like a second level, a second level of consideration, given that we do have some uncertainty from the federal. But it's not your intent to walk back previous additions to.
Correct. Everything that's on there would, but there might be modifications. So again, two types of Krabbe's, the one that we actually can test and make a difference should be tested for, but it presents some problems because the labs aren't necessarily going along. So you're right, it's not about removing anything from the list. It's about leaning into the expertise that we have and letting them do their job to inform our decisions based on Maryland's resources,
Thank you. I just want to make sure that we got your intent clearly on the record. Seeing no further questions, this does conclude the hearing on House Bill 1625 and our bill hearings for today.